So before we progress further, we need to assess those people. Most of them have non-specific symptoms in form of gradual onset to groin, sort of thigh, buttock, or even knee pain. They have intelligent gait and maybe started after minor trauma. When you examine them, there is reduced range of movement, particularly in internal rotation and abduction. Thomas's test may be positive or negative, and there's positive Trendelenburg test. There might be a leg length discrepancy, and you start investigating them. Get X-ray, AB, cross table lateral, abduction view to see how much coverage you get on the head. If this would help you to decide with the rotational osteotomy would help. Also false profile view. We'll go in more detail later through these X-rays. Also CT scan with 3D reconstruction, MRI, and DGMRC. Let's go in more detail about in these investigations. This is X-ray AB view of the pelvis. It's very important to get true AB, and the true AB, you need to see both hips on the side. You see the top of the iliac crest, and you see the as low as the lesser troch. Usually, if it is true AB, the distance between the tip of the coccyx and the symphysis pubis should be around 4 cm. This is very important to interpret hip geometry. This is the sociral, which is the weight-bearing area of the acetabulum, posterior acetabular rim, and this is the anterior acetabular rim. Normally the anterior is more medial than posterior. And you have the teardrop, which is, as we know, this is virtual lines seen on the X-ray. We might spot a crossover sign in which the posterior acetabular rim crosses with the anterior, and this points to the fact that the socket is retroverted, and this might be associated with hip dysplasia or impingement. A lateral X-ray. This is the AB of this patient, more or less the slice shallow of the acetabulum, but on the lateral we can see there's impingement. This, if you imagine this goes into flexion, this would impinge somewhere here. That's why it created some reaction there. False profile view, quite important to see the anterior coverage of the head, and this is the way it is done. The patient tilted in this way, the film is on this side, and the X-ray beam comes from this side. So you see this area, and this is what you see. This is the head of the femur. This is the greater trochanter there. This is part of the neck there. This is the ischium there, and this is the socket there. And we can measure the central edge angle on the lateral. So what is the central edge angle? Because I mentioned a few times, but I didn't explain it. Central edge angle, basically, it is the center of the head, vertical line through the center of the head, and another line to the edge of the socket. And this is what we call it, the anterior central edge angle. And the false profile view, you can do what we call the lateral central edge angle. Normally the anterior central edge angle should be more than 20, and on the lateral central edge angle should be more than 25. And basically this shows the lateral coverage of the head, and this is anterior coverage of the head. People with dysplasia, usually the lateral coverage is small, and the anterior coverage is small. There's another angle, or what we call a acetabular index or Tunis angle, in which it shows how vertical or how horizontal is the sociral. We know if it is the sociral, basically indicate the cartilage underneath, or show the alignment of the cartilage underneath, and we know the cartilage are very strong in compression but are weak for shear forces. So if the sociral is horizontal, probably the cartilage will be in his optimal condition. But if this is vertical, more in that way, there's a lot of shear forces going through the cartilage, and this can wear the cartilage quite quickly. So Tunis angle normally more than 10 degrees. a lateral subluxation index, which is the distance between the medial wall of the socket and the medial side of the head. Again, the actual value itself is not important, but we need to compare to the other side. The bigger, the worse. A CT scan with 3D reconstruction. Again, you can see the head clearly there, and you see how the cartilage, how much of the socket covering the head. Some centers, they don't do just 3D reconstruction; they do a model from chips or from plastic to aid the surgical planning by cutting or planning the cut on the model first before they do on the patient. MRI arthrogram and the GymRook. This is MRI arthrogram. You see the head there, the neck, and we see the dye inside. You can see, if you look there carefully, there's impingement there. There's the labrum quite prominent. You can imagine every time this guy flex, this impinge there. This is the GymRook. Basically, it assesses the quality of the articular cartilage. If there's high aminoglycogen, it will be whiter, and the less, it will be redder. So you can, this is more, the more red you see, the bad cartilage. This again help you with planning your surgery. The patient that you think he might benefit from rotational osteotomy, but the cartilage is not good, there's no point in doing this, because no matter what you do, the cartilage is poor, and he's going to develop osteoarthritis. Again, these are two different hips, both of them subluxed, and both the socket are dysplastic. But on this side there, it is morely red, indicating low glycosaminoglycogen, while on the other side it's fine. So probably this one you would consider hip replacement there, but you will do rotational osteotomy there. This patient had a rotational osteotomy on this side, and he had hip replacement on this side. So this can be a decision making tool